Dr. Jairani,
Yes.
you are
Yeah,
very
Preeti.
lucky. Dr. Chandravati madam has
Yes,
joined
yes.
after a long
I'm
time.
I'm
After a
blessed.
very,
That's
very
what I'm
long
telling.
time.
I'm telling everyone that Madam is there. She's the first one to join. So I was so happy
But
and
she
blessed.
joined the webinar after a long time. She was not joining. She was not keeping well, so she was not joining any of the webinars.
So it's a real great day for me.
Yes, for
So I'm
everyone, for all of us.
real blessing
For all
to
of
have
us, for
Madam
all
here.
of us.
Yeah.
Shall we start, ma'am?
Yeah.
Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, Knowledge Sharing Webinar, Bridging the Gap series, organized by UP Societies and Oxy. So it's my privilege to introduce the convener of today's webinar, Dr. K.S. Jairani Kamaraj ma'am. Ma'am is the director of Akash Fertility Center and Hospital in Chennai, Joint Secretary of TNFOG, President of Oxy in 2023, Vice President of TAPISAR, South Zone Coordinator of Oxy No2Wow Committee, and Associate Secretary of World Association for Sexual Health. I welcome you, ma'am, and I hand over the session to you.
Thank you, Sahiti. Very good evening and very much vanakkam to one and all. A very warm, immense wishes to Chandravati Madam. And I have the greatest pride and warmth to welcome you all for this webinar, which is jointly done by our Obstetric Gynec Society of Southern India with the Uttar Pradesh societies, mainly Lucknow, Kanpur, Hapur, Association of Delhi, Faizabad, Gorakhpur. And I'm very happy and honored to have one and all here for this webinar, which has been a academic sharing about the preterm birth and also about the preventive oncology. Because today we know today is the day of the awareness of oncology. So we have here a very important content to be discussed, that is the preventive oncology. On behalf of Oxy and all the Uttar Pradesh societies, I welcome the presidents, the secretaries, and everyone for gracing your immense time and grace your presence to be in this webinar. A very special, heartfelt thanks and namaskarams to our Chandravati madam, who is the real inspiration for all of us with her dignitary seat here to grace her presence to bless us. Thank you, madam. We welcome you for joining with us. A very special thanks to Dr. Preeti for being the greatest dynamic inspiration to make this webinar a grand success with her very dynamic secretary, Dr. Seema. So I'm very grateful to the Lucknow Society and all the president and secretaries of the society. A very special welcome to Dr. Sampath Kumari, our own dynamic president of Obstetric Gynec Society of Southern India, and our secretary, Dr. Meena Mahalingam. I welcome all the senior faculties who have joined from Lucknow, who have joined from Kanpur, Association of Delhi, Faizabad, Gorakhpur, Hapur, for being here and sparing your time to share your expertise and knowledge to share everyone about the lot of things related to the women's health. I welcome you one and all, and we'll start with a webinar with a prayer song, which is a prayer song we give to the Tamil goddess Tamil Thai Varthu.
நீராறும் கடலுடுத்த நிலமடந்த செழிகொழுவும் சீராறும் மதனவென எத்திசையும் புகழ் வணங்க இருந்த பெரும் தமிழனே தமிழனே உன் சீரிழமை திறம்பியந்த செயல்மறந்து வாழ்த்ததுமே வாழ்த்ததுமே வாழ்த்ததுமே
So after our humble tribute to the spirit, culture and strength of the Tamil Nadu, we will start lighting the Kuttuvilakku, a symbol of knowledge, purity and unity, as we invoke the light to dispel the darkness and the wisdom to guide action. We shall commence with the auspicious lighting of Kuttuvilakku, which is a symbol of knowledge, purity and unity. Lighting of Kuttuvilakku, Sahiti. Video is not coming. So we'll now move on to the inauguration. And I have the great pleasure, honor, and my great privilege to introduce and welcome our chief guest, Dr. Chandravati Madam, who is the patron of this Lucknow Obgyn Society, and she is the Professor Emeritus of Department of Obstetric and Gynecology of KG Medical College, the Proprietor Director of Krishna Medical Center, Lucknow, a Managing Trustee for the Krishna Educational Foundation of Lucknow, a Secretary of NGO Wheel, Women's Health, Empowerment and Education from Lucknow, a patron of the Indian College of Maternity and Child Health, and it's a private nursing home association, Lucknow. And she has been awarded a lot of awards for her great achievements, both in academic as well as in the social services to the women's health. Madam is the achievement of the Lifetime Achievement Award from UP Nursing Home Association, from UPCOG, Indian Fertility Society, Management of Association, Padma Shri, Dr. Raj Babaji Lifetime Achievement Award, and IOG, Dr. Satyapal Lifetime Achievement Award. And Madam has achieved the Mahalir Shakti Shiromani Award from in New Delhi in 2016 and 17. And she has done a lot of research, Patient Care Award from the Governor of UP in 2017. And she has been awarded the Inspiring Gynecological Indian Award by the Economic Times of India in 2018. And also she has a lot of awards for the improvement of women health from the Academy of, Indian Academy of Sciences. So she has been she has a lot of research publications, more than 65 papers in national and international journals, and guided over 150 theses for the postgraduates in the medical college. And she has been vice president of FOXI 2001 and 2002. And she has been the governing council member for 2 consecutive terms. And she was the peer-reviewed journal committee ICOG for 5 years and organized more than 20 state, national, and international level conferences. Madam, we are very blessed to have you here, and I'm really honored and privileged to have you here, ma'am, for your the inspiration for most of us. Over to you, ma'am, for gracing and blessing us, ma'am.
Thank you very much, Jaya. I think it was a really surprise for me when you called me and asked me to be chief guest for this program. I heard the topic. It was wonderful that you have connected with so many UP societies and with the southern societies, and your topic was bridging the gap with sharing knowledge. And I thought I will take out time and be with you, though I'm not keeping well and I cannot speak for a long time. But it was a pleasure. Both the topics you have chosen for today's webinar are wonderful. On preventive oncology, which is very, very close to my heart. And I've been involved in this for last many years, doing cytology, doing HPV screening, and doing HPV vaccination for all my women who attend my clinic. And I found that this has really brought success in bringing down the incidence of cervical cancer in my patients who have been visiting me. And I think now this has become a national program and people are really taking it up seriously. And I'm sure in due course, we will be able to bring down the incidence of cervical cancer in our country. And second topic which you have chosen is very, very thoughtful of you, preterm labor. This is also a wonderful topic because the incidence really is going up, the preterm labor, maybe because of so many things, the stress, the working women, type of diet we are having, so many factors are there. And you have chosen this wonderful topic. I'm sure all the delegates are going to get wonderful knowledge how to work up these two topics and how to work for preventive oncology and how to work preventive preterm labor. I wish you success for today's webinar, and I welcome and appreciate all the UP societies who have really joined, and I wish more and more delegates will join and get knowledge from your workshop today. Thank you, Jaya, again and again for inviting me today.
Thank you, ma'am. Thank you so much, ma'am. Thank you. Thank you for your blessings. Thank you for all your wishes, and which is very much close to my heart, and I cherish it too much, ma'am. Thank you, ma'am. Thank you so much. And I have the great pleasure and honor in welcoming and introducing the chief guest, Dr. Meera Agnihotri, madam. Madam is busy in a emergency, but I would like to introduce her. She's the professor and head of the OBGYN department of GSVM Medical College, Kanpur, presently the chairman of the Ethics and Research State Medical Council, and she's the president of the WWW Women's Association Foundation, and she's the advisor of the Women Health Cell Ministry of Health of Government of India, organized many international WW conference, first ever any conference inaugurated by the President of India and Union Health Minister. Madam is the recipient of various prestigious awards. One among is the Bury Edge Stott and Chancellor's Gold Medal, guided more than 300 research papers, theses, and MS and DPNB and PhD researchers. Madam represents India as the FOXI National Chairperson for the 9th FIGO at Montreal, Canada, and she is the visiting consultant at the Baylor College of Medical Department and Gynecology of Houston, Texas, USA. Madam has contributed in the national level, organizing secretary of the ACOG. It's actually ACOG, and chairperson for the FOXI AIDS Committee for 5 years till 2008. And she's the elected Governing Council executive member of ICOG twice. And she was the editorial panel of FOXI Journal, the Journal of OBGYN India, for 5 years. And she was the state president of FOXI 2011 3 times. She has organized 1 international and 3 national and 3 state conferences. The recent honors and awards between 2019 and 20 is the ICOG Ratnam Saman and Gold Plaque 63 in the ACOG 2020, and the Best FOXI Focus Award 63rd in the ACOG 2020, and Women Empowerment Award in the 62nd ASUOG in 2019 FOXI, and Lifetime Achievement Award in FOXI, ICES, and also she has got a Women Empowerment Summit Honor Award at Delhi in 2019. And she has achieved the Teachers of Teachers Saman ISPAT 2018 Award at Delhi. And she has been a person behind a lot of books and publications, being the chief editor of the book, The Women Empowerment, contributed chapters in many books, current trends in OBGYN practice, and delivered orations and keynotes in many academic platforms. We welcome you, madam. So we have the guest of honor. Can I have the CV of Dr. Preeti? I'm honored and privileged to welcome Dr. Preeti Kumar, who is the guest of honor. Madam is the president of Lucknow OBGYN Society, and she don't need any introduction. She's known for her work, what she has committed as a chairperson for the Safe Motherhood Committee, with almost utter commitment for the women of India, especially the rural population of Indian women. She has committed so much of work related to training, giving a lot of workshops, awareness among the healthcare providers for giving a safe motherhood.
Thank you,
Safe
Jairani.
motherhood. And I'm really proud and honored to be her friend, and I'm really look upon her as one of my inspiration in Foxy. Over to you, Preeti, for your words
Thank
of
you,
wisdom.
Jairani. Thank you, my dear friend Jairani. You're such a lovely friend. And I can see Aruna also smiling. So when I see your faces, no, it a lot of get a positivity. So thank you so much, Jairani, for making me part of this webinar and giving me such a prestigious honor. And we are very happy to see Dr. Sampath ma'am and Dr. Revati ma'am, whom we have high regards. So welcome virtually to Lucknow Society, Sampath ma'am and Dr. Revati ma'am. And we are really blessed to have Dr. Chandravati ji and Dr. Manju Shukla ji today on the webinar. And Seema has put in a lot of efforts for this webinar. She had been constantly calling me whom to take, whom not to take. So actually, a few days back, we were having one program on preventive, on HPV vaccination and all those things. So Dr. Uma Singh said a very nice words that every OB-GYN is a preventive oncologist. So they cannot be therapeutic, but every OB-GYN is a preventive oncologist. So let us, do as much as possible. And I think the topic which you have selected is apt for today's scenario. And we are seeing the lot of rise in the breast cancers also. We are putting a lot of efforts in screening the women for breast cancers, as Lucknow Obs and Gynae Society is taking a lot of initiatives on that. We have done mass screening. Almost 500 women have been screened for HPV DNA in rural areas. Lucknow Obs and Gynae Society conducted that screening program. And so whatever we learn, we should actually apply in the ground. So that's very, very important, because just doing webinars doesn't help. So, and the second one, as madam has already said, preterm labor, a lot of, the India is one of the second highest in preterm births. So a lot of initiatives are taken how to prevent preterm births. That's very, very important, because these babies are also at a risk of other problems later on in life. So, Jairani, I've seen you working a lot. I have also seen Aruna working, putting so much of hard work when Dr. Shanta was the president. And I think every conference she works like puts in a lot of effort, very sincere and very dedicated. And Jairani, I've seen you as a president of Oxy. And the kind of work, I was there for your ceremony when there was a changeover of guards. The kind of work you had done for the Oxy is commendable. So I really wish and pray that people like you and Aruna should, come forward and serve Foxy also. So our full support and best wishes for you, both of you. Both of you are very close to my heart also. So all the best, and I want to see you right there and do the similar kind of work for Foxy as well. So thank you so much once again, Dr. Jairani, Dr. Aruna, Dr. Revati ma'am, Dr. Sampath, everybody from South collaborating with the North, especially UP societies, and the exchange of thoughts in the management of these two, the preventive oncology part and the preterm labor will give a lot of insights today in this webinar. So thank you once again, and all the best.
Thank you,
Aruna
thank
and
you, thank you,
Jairani.
thank you,
Thank you.
Preeti. Thank you so much for your kind words and nice wishes for us. And we really, me and Aruna will definitely stand up to your expectation, and
Yes,
we'll make
Yes,
our
thank you.
positive
you have
impact
to.
in the
You
Foxy.
have to.
Thank you,
Definitely,
Preeti
we'll do
ma'am.
it.
Thank you so much.
Thank you
We've
so
been very
much for
happy
all.
meeting
Thank
you.
you, thank you so much. And
So a lot
I
of
have the
leaders, Dr. Sampath, Dr. Revati ma'am, they're very strong leaders. So I've seen Dr. Sampath also working, Dr. Revati ma'am when she was vice president, great academician, both of them. Thank you, ma'am. Thank
thank
you so
you,
much.
thank you,
Thank
thank
you.
you, thank
Thank
you,
you,
ma'am.
Preeti.
Thank you,
All
Preeti
the
ma'am.
best, Jairani and Aruna.
Thank you, ma'am. Thank you, ma'am. Thank you,
Thank you,
ma'am.
ma'am.
We are now, I have the great pleasure and honor to welcome and introduce our special guest, Dr. Manju Shukla, madam. Madam is the patron of the Lucknow OB-GYN Society, and she's a retired professor of OB-GYN from KGMU Lucknow, and Madam is the retired professor and HOD of OBGYN CMSH Lucknow, President of the UCOG, President of Lucknow OBGYN Society, Chief Editor Journal of UPOC, President Association of Private Gynecologists of Lucknow, Master Trainee of Contraceptive Technology of Jepaigo, Master Training of EMOC, and Master Trainer in Maternal Health, and trained in Quality Assurance of NQAS, National Assessor of Quality, and Lakshya Kaigal in NRHM. Madam, we welcome you and kindly bless us with your wishes, ma'am.
Thank you, Jaya. I was just came from the NAC inspection. I was there only.
Thank you, ma'am. Yeah, ma'am.
Thank you very much for inviting me in this webinar, which is very, very important. It has two topics: prevention of preventive oncology and premature labor. Both are very important because preventing cancer is now possible by awareness and HPV vaccinations, cervical cancer, and breast cancer also by regular checkups and self-breast examination also. So the topics are good. Premature labor, yes. Prevention is very, very difficult. Sometimes you have to have surrender for this. So delegates will learn a lot from you all, and all the best, and enjoy the webinar.
Thank you, ma'am. Thank you. Thank you so much for your kind blessings, ma'am. And thank you so much for joining us in midst of your busy schedule, ma'am. Thank you so much for your words. And I have now the great pleasure and honor to welcome my own dearest president of OXY, Dr. Sampath Kumari, who is a dynamic adolescent, but always active, who is our dynamic president of OXY and our past vice president, who is the Senate member of Tamil Nadu MGR Medical University, who is the professor and HOD of Sri Muthukumaran Medical College, and also the national corresponding editor of Journal of OBGYN Jogi, and founder secretary of Tamil Nadu Federation, now the president of our OXY, and she is the retired deputy director of IOG Chennai and the president of the Board of Studies of Tamil Nadu MGR Medical University between 2015 and 19. And she was the chairperson of the FOXY Adolescent Health Committee. And we all know her dynamic work, which she does from Kashmir to Kanyakumari, individually touching every adolescent of India with all her power and energy and awareness, walkathon, marathon, everything. She's so much attached with the adolescents, and we are really proud to have her as our president. And she's the chairperson of the women's wing of IMA Chennai South, and the IMA National President Award she got, and she got the IMA TNSB Award 2021. We welcome you, Sampath, from US to share your words of wisdom.
Thank you, Jairani. It's nice, wonderful to be with this webinar. It is really a great pleasure to have our OXY with all the UP societies. Really thanks to Dr. Chandravati Madam, Dr. Meera Agnihotri Madam, Dr. Manjusha Madam, and our Preeti and Seema for organizing this wonderful topic. And Aruna and Jairani, this time definitely you are the chairpersons in FOXY, I think. Best wishes to Dr. Aruna and Dr. Jairani. And the topics you have chosen, that is the preventive oncology. As Preeti was telling, from OXY also, we are working for that 90-70-90. We have to individually, we have to work for screening the mother and vaccinating the adolescent. By that way, we can reduce the incidence of cervical cancer and all other cancers, the breast cancers, the awareness. As far as we are talking about the counseling and the awareness, we can reduce the incidence. That is the preventive oncology, which is the topic Dr. Jairani has chosen. And then the preterm labor. What will be the complications to the baby? So with the moderator, with the panel, we can discuss about, we can hear the delegates can understand about the etiology and the prevention and what will be the complications. The two topics are really good. And thanks to UP Societies, Preeti Kumar. She is one of my best friend, and we are eagerly waiting for your vice presidentship next year, Preeti. We will have a great work. As committee chair itself, she has done a wonderful work and tried to reduce the MMR. So all the best for the webinar, and all the best wishes to Jairani and Dr. Aruna. Thank you.
Thank you.
I wish
Thank you,
all the
Sampath.
UP societies should vote for Aruna and Jairani. Thank you.
Thank you
Thank
so
you,
much,
thank
madam,
you,
for all the
thank you,
blessings.
thank you,
Thanks.
Sampath. Thank you so much. So, thank you so much. A very special thanks to the chief guest, guest of honor, special guest, for blessing us with your wonderful wishes, which is the real blessing that we get in this academic sessions. So now we'll move on to the academic sessions. We are moving to the first session of this webinar, which is the preventive oncology. I have the great pleasure and honor in welcoming the chairperson, Dr. Zaid Rizvi Dikshit, madam, who is the president of Faizabad. I think madam was busy in a family commitment, so she said that she may join. And I have the great pleasure to welcome Dr. Savita Agarwal, who is the president of, she's the president of Kanpur. No, she's the president of from Jhansi, and I'm very happy to honor to have her, madam. And I have the pleasure to welcome Dr. Vidya Chaudhary. Can I have the CV of Dr. Vidya Chaudhary? No, you go to the next one, Vidya Chaudhary. Yeah. So, madam is the professor of OBGYN Department of Maharani Lakshmibai Medical College, Jhansi, and she has special awards and achievements, awarded fellowships from ICOG and ICMCH in 2013, awarded by the Honorable Health Minister for maximum insertion of PPIUCD in Bandarkand region in 2015, member of Public Awareness Committee between 2014 and 16, member of Safe Motherhood Committee in 2020 and 23, and she has contributed one chapter in the second edition of the Practical Cases in OBGYN, edited by Dr. Kannan Yekar, co-editor the Bulletin of Public Awareness Committee in 2016, and she has more than 20 publications in various indexed international and national journals, and participated as a faculty in many national, zonal, and state conferences and workshops. We welcome Dr. Vidya Chaudhary, and over to you, chairpersons, to chair the first session. And we have the experts here for this first session. Dr. Kalpana Dikshit, madam. She is the director of the Jivani Hospital. She is the organizing secretary of the WW NatCon 2023. She is the vice president of the KOGS, master trainer of GDM Foxy 2019. She has organized many of the conferences like WWW International Conference in 2018. And she has organized the National Conference of OBGYN UPOG 2017 to 18. We welcome you, madam, to be the expert for this session. And also, I have the great pleasure to welcome Dr. Kamna Datta, who is the secretary of the Association of Delhi, to be the expert for this session. Over to you, chairpersons. I think Dr. Vidya is here. Saruna, you are here?
Yes, Jaya.
You just introduced Dr. Meena.
Yes,
I think
yes. Thank you for the opportunity. Yes, introducing a really sincere worker like Meena Mahalingam. It gives me a lot of pleasure and privilege. I welcome Dr. Meena Mahalingam, who has got a special training in urogynecology, microsurgery, endoscopy, instructor, basic newborn care and resuscitation program under IAP. Clinical experience is 23 years in Tertiary Care Teaching Institute. Academic activity master trainer for EMONC. Yes, and faculty organizing member in national and international conferences. Membership Foxy, Oxy, IUGA, and etc. She has research work done at 8 publications, including 5 original articles. At community adolescent health camp and blood bank camps she has conducted. participated in district instructor in IAP, NRP, and FGM training of HCW in NRP. Received scholarship of IUGA for attending IUGA conference in Italy. Best Doctor Award 24. Won awards for scientific paper presentations. I welcome you. She is a secretary of OXY, co-chair Urogynec Committee OXY, member Urogynec Subcommittee for OXY. I welcome you, Dr. Meena Mahalingam. Please take the charge.
Thank you, Jayarani Madam. Thank you, Sampath Kumari Madam. Thank you, Aruna Suman Madam, for the kind introduction. I thank UP Society and our own society for having given this opportunity to talk on preventive oncology, which is very, very important to, as we all know, prevention is better than cure. During midlife, we do encounter all cancers. So we will go through each cancer and their statistics. Chitrakala, next. I thank Nimi Madam for having shared her academic content. We know that prevention is better than cure. Always we need to have a good screening. India being a kaleidoscope of contrast. Next. We have the ICMR statistics wherein they say 8 women die of cervical cancer. 1 woman dies of cervical cancer every 8 minutes in India. For every 2 women newly diagnosed with breast cancer, 1 woman dies of it in India. As many of 2,500 persons die every day due to tobacco-related disease in India, and smoking accounts for 1 in 5 deaths among men and 1 in 20 deaths among women, accounting for an estimate of 930,000 deaths in 2016. Next. Coming to cancer in India, the ICMR data of the oral cavity and lung in males, cervix and breast in females account for 50% of all the cancer deaths in India. The top 5 cancers in men and women account for 47.2% of all cancers. These cancers, they can be prevented, screened for, and detected early and treated at an early stage could significantly improve the outcome. Now, coming to the top 5 cancers in men, it could be the lip or the oral cavity, the lung, the stomach, colorectum, and the pharynx. For women, it is the breast, CA cervix, colorectal cancer, ovarian cancer, lip, and the oral cavity. Coming to the cancer statistics, as a statistical data, as per the modeling data, the projection is that breast cancer cases will usually around 250,000 by 2030. That is what is an estimate given by the modeling data. Currently, there are approximately 182,000 cases of breast cancer in India. To prevent these cancers, we need to have a extraordinary screening method for CA breast, especially coming to most common cancer in women accounting for 27% of all cancers is the breast cancer. Next. In Globocon 2012 data, new cases registered were 1,44,937. Currently, the statistics is around 1,82,000 and the death due to this cancer is 70,218. The incident rates in India begin to rise in early 30s and peak age is around 50 to 64 years. Overall, 1 in 28 women is likely to develop breast cancer during her lifetime. In urban areas, it is around 1:22 and in rural, it is 1 in 60. The next common cancer is a cervical cancer, the second most common reported, accounting for 22.8%. In Globocon 2012 data, the new cases registered were 1,23,000, death reported were 67,500, and median age is 38 years, ranging from 21 to 67 years. The rural women are at a higher risk of developing cancer cervix as compared to the urban counterparts. Now coming to the preventive oncology. It is a proactive approach that combines regular screening, health education, and awareness lifestyle changes to reduce the risk of cancer in midlife and beyond. The health education and awareness is very, very important, starting from school age, regular screening, giving a lifestyle modification, genetic counseling and testing, hormonal factors, giving adequate vaccinations, health monitoring, and mental health support. Now, let us move on to see some case scenarios. Mrs. S, 52 years old, mother had CA breast at age 60 and died 4 years later. And she was overweight, leading a sedentary lifestyle, no current symptoms but concern due to family history. So, how are we going to prevent a breast cancer for this woman? So, this woman requires regular screening, start annual mammogram at the age of 40 or earlier if there is a strong family history. Self-breast examination cannot be kept as a second step. It is a first step to detect any unusual changes. The woman has to do a self-breast examination when she is doing a shower, using the right hand to examine the left breast and the left hand to examine the right breast. Slowly move it on, and also examining the breast in front of the mirror to see for any abnormalities, any PUD orange changes, or if she feels a mass, she has to report to the medical officer immediately. The important thing is lifestyle modification, that is a healthy diet and regular exercise, which cannot be explained more. The lifestyle medicine is coming up. And coming to the genetic testing and preventive surgery, discuss the options for genetic testing like BRCA mutation genes if there is a family history of BRCA related cancers. And also when there is a family history of having a breast CA in a mother. If positive, we need to consider doing a mastectomy and follow-up, that is surveillance. Now, we all know about the Angelina effect, wherein she had double mastectomy plus genetic testing in the spotlight. So her choice, what had happened is doing a BRCA1 testing. Genetic test can check BRCA1 and BRCA2 mutations in people with a family history of cancer. Women who have inherited mutations in these genes face a much higher risk of developing breast and ovarian cancer. So in numbers, 1.5 lakh Indian women who are diagnosed with breast or ovarian cancer. Madam? So 1 in 5 lakh Indian women who are diagnosed with breast or ovarian cancer every year, 5 to 10, that is 10,000, may have familial cancer and may benefit from BRCA1 or CA2 gene testing after genetic counseling. 4 to 6,661 ovarian cancer cases projected by National Cancer Registry Program. Now, moving on, we'll see a case of cervical cancer. This is a Mrs. E, 45-year-old, no known family history of any cancers. She has 2 full-term normal deliveries. Her last childbirth is 20 years when she was around 25 years. No significant health issues and never has had a pap smear. How are we going to screen such women? In our country, we do not have a regular screening for all the women. We do have a screening only when the women comes to us. Now, in our state, we do have Makkalai Thedi Marthuvam, wherein we are doing screening for all women, spreading through rural and urban. So, it is important to have a regular screening with pap smear starting at the age of 21. Women aged 21 to 29 should have a pap test every 3 years. Women aged 30 to 65 should have a pap and HPV co-testing every 5 years or pap alone every 3 years. And coming to, as Sampath ma'am told, HPV vaccination, we are having this 90-70-90 target, encouraging HPV vaccination for preteens, recommending between 11 to 12, but can go up to 26 years. We now have this FOGSI GCPR recommendation, where in less than 15, we do give 2 doses, and more than giving 15 years, 0, 2, and 6, 3 doses. And also discussing the potential benefits for women up to age 45 who have not been vaccinated. Lifestyle modification, again re-emphasizing, promoting a diet rich in fruits, vegetables, and whole grains, which may support overall health and immune function. Encouraging regular physical activity to maintain a healthy weight. Now, CA cervix, smoking cessation should be done ideally. Strongly advise our women against smoking and provide resources for quitting, as smoking increases the risk of cervical cancer, and also reiterating safe sexual practices, discussing the importance of safe sexual practices, including using the condom to reduce the risk of HPV transmission, and follow-up care, emphasize the importance of follow-up and adherence to screen guidelines, especially after abnormal results or a positive HPV. Now, to summarize about CA cervix, cervical cancer prevention, HPV vaccination as a method is to be adopted. Safe sexual practices, regular screening and follow-up, a healthy lifestyle based on diet and exercise, ensuring that women stay up to date with pap test and HPV vaccination can significantly reduce the risk of cervical cancer. Now moving on, we do have a case of ovarian cancer. Mrs. M, 48 years old. Mother had ovarian cancer at age 62. Grandmother also had breast cancer. Moderately active woman maintaining a healthy diet, has had regular gynecological checkup. No significant health issues. Here, the patient presents with the complaints of persistent abdominal bloating. Next slide. Pelvic pain, frequent urination over the past few months. Clinical examination, ultrasound, CA 125 taken. Diagnosed as cancer stage 3, ovarian cancer. Now, how do we prevent ovarian cancer in such women? So, helps identify genetic testing, mainly mutations BRCA1, BRCA2 that are associated with increased cancer risk, and surveillance and screening. Discuss the importance of regular gynecological examination. Routine screening for ovarian cancer is not recommended for all. We do not have routine screening for CA ovary. Those at higher risk may benefit from transvaginal scan and CA 125. Now, women with BRCA mutation or strong family history may consider risk reducing such as bilateral salpingo-oophorectomy after childbearing, because we know that fimbrial end of the fallopian tube can act as a drop metastasis or P53 signatures. Also, they can give rise to stick tumors, that is a serous tubal intraepithelial cancer. Now, how are we going to prevent? The oral contraceptives, we say Fetellah's incessant theory of ovulation, which states giving a ovulation-free period using a oral contraceptive pills will act as a chemoprophylaxis. So it is important to discuss the protective effects of oral contraceptives, which have been shown to reduce the risk of ovarian cancer. Long-term use, 5 years or more, can significantly lower the risk. Healthy lifestyle choice, maintaining a balanced diet rich in fruits, vegetables, and whole grains. Regular physical activity can help maintain a healthy weight and potentially reduce their cancer risk. Limit alcohol consumption and avoid smoking, both of which have been linked to various cancers. Now moving on to the next cancer, the colorectal cancer. Mrs. J, 58 years old. Her father had colorectal cancer at her age of 65. One sibling diagnosed with polyp, and she has a sedentary job, consuming a high diet in meat, especially meat with a high diet. They tend to have a colorectal cancer. Recently, she started experiencing change in the bowel habits, including intermittent diarrhea and blood in stool. So this woman also feels more fatigue than usual, loss of bit of weight without trying, concern, and she is seeking medical help. Colonoscopy states she is having a colorectal cancer. How are we going to prevent these women having a colorectal cancer early? Encourage a routine screening for colorectal cancer starting at the age of 45 or earlier for those with family history or other risk factors. Colonoscopy should be done every 10 years in these women who are supposed to have a high risk of family history having a colorectal cancer. Using a flexible sigmoidoscopy every 5 years. Fecal immunochemical testing, that is a FIT, annually, and also maintaining a healthy diet, promoting a balanced diet rich in fruits, vegetables, whole grain, and fiber. Limit the intake of red and processed meats as they have been linked to increased cancer risk. Encourage consumption of food and high in antioxidants, especially colorful fruits and vegetables, and calcium intake. Now, the physical activity, what they can do is recommending a regular exercise, which have been associated with the decreased risk of colorectal cancer, aiming for at least 150 minutes of moderate activity or 75 minutes of vigorous activity per week. Maintaining a healthy weight, discuss the importance of managing weight, as obesity is a known risk factor for colorectal cancer. So the preventive strategy for colorectal cancer would be doing a genetic counseling. If there is a strong family history, consider referral for genetic counseling and testing for hereditary syndromes such as Lynch syndrome or familial adenomatous polyposis. Awareness of these symptoms, educating individuals about potential symptoms of colorectal cancer such as changes in bowel habits, unexplained weight loss, blood in stool, persistent abdominal pain. Encourage them to seek medical advice. During screening examination like colonoscopies, if there is a polyp which is identified, detected, it should be removed before they become cancerous. This proactive approach significantly reduces the cancer. So midlife is a time to simplify the life and enjoy living. Thank you. Thank you for the patient listening.
Thank you.
Thank
Thank
you.
you, Dr. Meena.
Thank
That
you,
was
ma'am.
an excellent talk, very clear. And you told us about the prevention of all aspects by the lifestyle modifications. What is the diet that we should take and the exercise, and how to create awareness in the women who come to us for our OP. Thank you so much. That was a really nice presentation. Very crystal clear it was.
Thank you, madam.
Thank you, Chairperson. Thank you, Aruna, for your kind
Thank you, Jairani.
taking up. Yeah. So we are now moving on to the next session. I have the great pleasure and honor in welcoming Dr. Alpana Agarwal. Can I have the CV of Madam? She is the Secretary of the Gorakhpur. We welcome you, Madam. Can I have the CV of Dr. Alka Sethi? She is the President of Jhansi. We welcome you, Madam. And Vidya Chaudhary also, you just have it. Yeah, Madam is the Secretary. She is the Professor of OBGYN Department of Mahalakshmi College of Jhansi, and she is the Secretary of Jhansi Society. We welcome you, Dr. Vidya Chaudhary. Is our chairpersons are there? I saw.
We should, Dr. Jairani, we should actually recognize the presence of Dr. Revati Janakiram, Madam. She is here.
Madam
with us.
is there, no? Madam?
Yes. And she can be our expert too here.
Yeah. Madam
Such a
can be there,
knowledgeable leader she is.
yeah.
Hi, ma'am.
Yeah.
Good evening. Nice
Hi,
to
ma'am.
see you. I feel very happy meeting you also.
So nice of you.
So it gives me great pleasure and honor to welcome the moderator of this panel, Dr. Renu Singh. She's the Professor of Department of OBGYN of KGMU Lucknow. She's the FIGO and ICOG Fellow, and she's an RCOG Associate Member, and she has presented papers in the international and national conferences, and she's the national and international publications, including book chapters, and she's the ex-Joint Secretary of Lucknow OBGYN Society between 2012 and 14, and the executive member of Lucknow OBGYN Society, and also is the co-editor of the newsletter of Lucknow OBGYN Society between 2017 and 19, and her area of interest is high-risk pregnancy and the prenatal diagnosis. We welcome you, Dr. Renu Singh.
Thank you, ma'am, for the kind introduction.
Can I have the CV of Dr. Sonia Luthra? I think Madam's CV was Madam is also from Lucknow. She's the professor of the Hind Medical College, and we welcome you, Madam. And over to you, moderators, for moderating this panel on preterm birth prevention and management. And we have with us our expert, Dr. Aruna Suman, who is the professor of the OBGYN, HOD of the Government Medical College of Jagattal, Telangana, and she is the Joint Secretary of the FOXI 21, and she is the Organizing Secretary of ACOG, Hyderabad 2024, and she has been in the National Coordinator of the No to Violence Against Women Committee.
Thank you, Jairani.
We welcome you,
so much.
Aruna. We welcome you, Aruna. And I have the
Thank you for
pleasure
the
to welcome
opportunity.
Dr. Seema Mehrotra, who is the person who is behind this successful webinar, who has been organizing all the faculties. I thank you, Seema. A very special thanks to you.
Thank you so
And
much,
she's
ma'am.
the Secretary of the Lucknow OBGYN Society and the Secretary of ISOBAB Lucknow Chapter 2021-24. And she is the member of the Medical Education Committee of FOXI 22-25 and member of the Safe Motherhood Committee FOXI. And she is the member of the Executive Council of the Indian Menopausal Society and the Lucknow OBGYN Society between 2019 and 21. She is the Joint Secretary of the Lucknow Society between the 17 and 19. And she is the member of the FOXI Young Talent Promotion Committee between 2017 and 19. And she is the recipient of many awards, one being the Commonwealth Fellowship in 2013, FIGO International Fellowship in 2009, Young Doctor Summit Travel Award by International Society of Gynec Oncology in 2012, and Professor S.S. Ratnam Young Gynecologist Award in 2018. And her area of interest is obstetric ultrasound, fetal medicine, and high-risk pregnancy. We welcome you, Dr. Seema, to be the
Thank you, ma'am.
expert for
Thank you so
this
much, ma'am.
panel. And over to you, the moderator, to welcome and introduce your panelist.
Thank you, ma'am.
Dr.
Just let me share my say, ma'am, PowerPoint. Is it visible, ma'am?
Yes, yes. But put it in a
Yes, yeah, sure.
slideshow mode.
Is it
Yes.
visible, ma'am?
Yes, it
Yes,
is.
it is. Yes.
Yeah. So I thank all the organizers for giving me this opportunity and welcome you all. And I also welcome my esteemed panelists. And the panelists are Dr. Reshma, Dr. Uma Sharma, Dr. Sangeeta Mehrotra, Dr. Indu Lata Sahu, Dr. Parul Sinha, Dr. Gomati, Dr. Kritika, Dr. Archana, and Dr. Bharani. So welcome you all. And I hope that we will do justice to this panel. And that the panel is on preterm labor. So before I start, I just want to bring you certain facts about the preterm labor. We know that preterm labor is the onset of labor prior to 37 completed weeks. It contributes to nearly 50 to 60% of the preterm births globally. The incidence of preterm labor in India has been quoted to be about 23.3%. About 3 million preterm births they have happened in India in the year 2020, and which contributed to about 20% of the global burden. It contributes hence so much to the perinatal morbidity and mortality. So this data of India was being taken from the talk conclave which happened on the preterm labor. The management of preterm labor in India is challenging. It owes to the demographic variations that we have in our country. There is different healthcare infrastructure variations, the different the disparities in the socio-economic conditions. So there is different in the access to quality antenatal care and definitely access to the skilled healthcare providers. So all these factors, they come into play and they make the management of preterm labor very challenging in our setup. So my first question is to Dr. Bharani, that what are the criteria for diagnosis of preterm labor? Is madam here?
Yeah, I'm here, ma'am. Bharani here. So normally anybody who gets into labor before 37 completed weeks of gestation is when we call them preterm labor. And whenever she comes with cervical dilatation of more than 2 centimeters, and if she's getting more than 4 contractions, and for us in India, we still consider 28 weeks as period of viability, but sometimes even 24 weeks is okay. So after 24 weeks period of viability and before 37 weeks of gestation, if anybody gets into labor, then we call it preterm labor.
Yeah, right, ma'am. So this definition of preterm labor that I took from our Foxia Society, and it happened in the talk, conclave in the preterm labor. My second question is, what are the different categories of a preterm birth as per gestational age?
So basically, based on the period of gestation, we can classify them as either 2 ways, either very early preterm, that is if they deliver less than 34 weeks, and late preterm is anywhere between 34 weeks and 37 weeks of gestation, that is 36 plus 6. Previously, the WHO used to tell based on, again, extremely preterm is anybody born less than 28 weeks, and some 28 to 32 weeks was very preterm. 32 to 34 weeks is moderate preterm, and 34 to 37 is late preterm. So anything over 34 is late preterm, and before 34 is early preterm.
Yeah, so that is right. And our even Foxia Society has also given this particular classification into extremely preterm, very preterm, moderate preterm, and late preterm.
Kidney or spine.
So now coming to a case, Mrs. A, 30 years, gravida 2, para 1, live 1, 30 weeks gestation. She comes in emergency with pain abdomen since 8 hours and discharge per vaginum. She has a previous full-term delivery. On examination, her vitals are stable. She's 30 weeks, longitudinal lie, cephalic, mild contractions are there. And the fetal heart sound is regular. Per speculum examination is NAD. And on PV examination, her cervix is 2 centimeters dilated. So my next question is to Dr. Reshma, that what is the probable diagnosis in this patient?
Hello, everyone. This patient is clear-cut having the symptoms of preterm labor. And my diagnosis is obviously preterm labor. She is in preterm labor. Yeah.
Okay, ma'am. So what are the at-risk factors in general for say preterm labor?
Generally, the risk factor for the preterm labor are there are certain factors which are low socioeconomic status leading to nutritional deficiency, anemia, cigarette smoking, drug abuse, and if there is prior history of preterm labor in previous pregnancy, and if there is any signs of infection in the uterus, asymptomatic bacteriuria or recurrent UTI, any symptomatic bacteriuria or asymptomatic, both, and recurrent UTI, if there is history of any uterine anomaly, in that patient, the patient will give the history of, if it is second para, the patient will give the history of, previous history of preterm labor also. That will be, and if there is a lack of proper antenatal care. So we can divide these factors into modifiable and non-modifiable. So in modifiable factors comes the nutritional deficiency, lifestyle changes, any oral infection, any bacterial, vaginal and urinary infection, any stressful work or strenuous work which can be avoided, that comes under the lifestyle management. And among non-modifiable risk factors, there is prior history of preterm labor, we can prevent it in next pregnancy. And there are certain age factors. If it is less than 18 years or the patient is elderly primary, more than 40 years, then we can always do in that condition, we can prevent it before this. And if the nutrition is lacking, we can promote it by giving nutraceuticals. And if there is low weight gain during pregnancy, it can be prevented. And if there is modifiable risk factors, there is previously if the patient is having any uterine anomaly, so we can correct it before being pregnant.
Yeah.
And if there is any infection, history of any UTI, we can prevent it.
Yeah, rightly said, ma'am, that while we take history of these patients, there are many factors which are modifiable risk factors, and there are many which are non-modifiable. So depending upon these, we can definitely guide the patients regarding the preventive strategy that the patient has to do. Now, a repeat examination is done few hours later, and it finds that there is an increase in the frequency of uterine contractions, and the cervix is now 3 centimeters dilated. Is there any role of tocolytic therapy in this woman who has a very high chance of preterm birth? What is the rationale for using tocolytic, say, in this woman? And what is the drug of choice? And say, in regard to the WHO recommendations. So this question is to Dr. Uma. Ma'am, are you there? Hello?
The role of tocolysis. I'm Dr. Gomati.
Gomati. There is no one by name Uma.
Okay. The name that was given to me.
I'll proceed, ma'am.
Yeah. Okay. No issue.
Yeah. There is definitely a role of tocolysis because it permits the use of antenatal corticosteroids, and it gives times to give us a neuroprotection magnesium sulfate. So we're making a delay of 48 hours or minimum, so that we can have a pre-planned idea that we can shift the patient to tertiary care center, check for the availability of NICU, check for the in utero transfer or the mode of delivery. We can plan accordingly, see for the neonatologist and everything. So definitely the role of tocolysis plays a role.
Yeah. And ma'am, the second part of the question is that if we wish to use tocolysis, then which tocolytic has to be used? And what is the recommendation in regard to WHO?
Actually, the nifedipine is recommended because it is very safe, and it should be that there should be the patient should have no contraindication for tocolysis, and the patient should have a gestational age that should have crossed the viability. It should be a viable baby, so it should have been at least 24 weeks to less than 33 weeks, and there should be definitely a spontaneous preterm labor or a suspected preterm labor should be diagnosed. So definitely the nifedipine plays a role.
Yeah, ma'am. So you at least said that the WHO has given recommendation that because nifedipine is a safer drug, this particular drug is easily available. So that should be given to women, and it should be offered to women who are in suspected or diagnosed preterm labor. And regarding dose, madam? What shall
Because
be the dose?
it is orally available and it is easily available and the cost is less. We should not give a sustained release and we should not give a sublingual nifedipine. So the nifedipine doses, initial dose is 20 milligram, followed by you can give 10 milligram TID or QID depending upon the need. And it should be given for a minimum of 48 hours to 3 days or maximum 7 days, not more than that, because this is the time period the mother needs to get accommodated or the transfer is whatever happens. So it is the drug of choice.
Yeah, so you rightly said, and WHO has said that many of the drugs who like the oxytocin receptor antagonists, the nitric oxide donors, they are not available in many countries. They can be costly. So it is not recommended by WHO, and the drug which has been recommended by WHO as a tocolytic in women with suspected preterm labor is nifedipine. So thank you, madam. Now, my next question is to Dr. Sangeeta. Now, which are the other drugs that can be used for tocolysis, and what are the contraindications for tocolytic therapy?
Yeah, there are many drugs which are available, although the WHO recommends only nifedipine, which is the drug of choice. The other drug of choice, but according to the FOXY, it is the calcium channel blockers. It is a nifedipine, but the beta mimetics which we have been using since long. That is the isoxsuprine. It is still recommended by the FOXY GCPR. And the other drug which is recommended by the FOXY, it is atosiban or the oxytocin antagonist. So these are the drugs, and in very limited or very less or very small group of patients who have polyhydramnios, in those patients we can give a short course of indomethacin also. It is sometimes recommended, although it causes some side effects in the fetus. That is, it causes the constriction of the patent ductus arteriosus, and it also causes the oligohydramnios. So it is not very well accepted and it is not used regularly. What we are using, it is nifedipine, and if the patient is contraindicated for nifedipine, that is, she is having some cardiac issues, the other drug of choice is atosiban. Otherwise, even in IVF precious pregnancies, we are using atosiban, although it is not readily available everywhere and it is very, very costly. But still, seeing the benefit and the risk, we still go for atosiban in IVF pregnancies and in certain subgroup of patients where nifedipine is not preferred.
Yeah, madam. Yeah,
talking of the tocolysis,
the contraindications,
the contraindications, we have to divide between the maternal and the fetal contraindications. Talking of the maternal, the most important contraindication is the chorioamnitis and the PPROM, and also the cardiac issue. If there is any cardiac problem in the cardiac disease in the mother. Others could be severe preeclampsia and eclampsia, and if she is having any placenta previa or she is having any maternal bleeding leading to the hemodynamic instability. If we think of the fetal causes, it could be an IUD or any congenital anomaly which is not compatible with life in the fetus, or the fetal status is not fetal status is not reassuring. In such cases, we will not offer tocolysis at any cost.
Yes, ma'am. So we have, so definitely these women who are in, say, suspected or established preterm labor, they need tocolysis, but definitely the drug which has been recommended by WHO is nifedipine. But the FOXY recommendations, they say that isoxsuprine is the preferred drug because this particular drug has been approved by CDSCO, and there are many other drugs. So FOXY says that isoxsuprine is the drug of choice because we have a long experience over 6 decades. It is also recommended for maintenance tocolysis. This particular drug effectively prolongs pregnancy. It delays delivery by more than 48 hours, and it improves thereby the perinatal outcomes when used in appropriate doses. So FOXY recommendation is on the drug isoxsuprine. Now, madam, I request what shall be the dose of isoxsuprine?
See, isoxsuprine can be used in the last trimester after 34 weeks only. It cannot be used in the second trimester because it will cause hypotension, giddiness, and etc. There is a decreased blood supply to the placenta also, which can lead to fetal growth restriction. There are few studies. So it is safe. Yes, it is safer in the last trimester.
Yeah, ma'am. So
when we were residents, like we have been, like we were young, we used isosoprin, like that was the only tocolytic that we were using.
Yes.
And we don't remember like having any side effects. It went into disuse because of the certain reports which came because of the maternal hypertension and fetal tachycardia it caused. So that is why maternal tachycardia. So that is why it went into disuse. But like we have a lot of experience. I think all the people of my age group, I think they have used.
Yes. Initially, we discontinued it, but later on it came back again. But it can be safely used in the last trimester rather than the second trimester.
And if we are using nifadafine, then magnesium sulfate cannot be used simultaneously. We have to be
That's a very good
cautious.
point, Sangeeta. Yes, we have to bring out that
Together,
point.
if you use them, it causes maternal, because both of them cause vasodilatation and lead to hypotension, and in some cases
cardiac arrest can happen.
My one query is, ma'am, that this particular article, it writes that it is off-label use of nifedipine in tocolysis. What the FOXI guidelines says, that nifedipine is off-label use for tocolysis. Is it like that?
Yeah, yes. CPR says that only, that it's an off-label use. And azoxuprine, we can use it as well as maintenance tocolysis.
Oh.
Whereas nifadipine is not for maintenance tocolysis.
Yes.
Yeah.
It can be used only for 7 days, 3 to 7 days, not more than that. We cannot maintain it.
Yes.
Say the concept again is, ma'am, they're very controversial whether we want to prolong the pregnancy by more than say 48 hours, because whatever the effect that we want of the corticosteroid and of the magnesium sulfate is only for 48 hours time. So what is the point in prolonging the pregnancy beyond say 48 hours or say 7 days? So nifedipine stands there. So my next question is to Dr. Kritika, that should women with preterm contractions but no cervical change need to be treated with tocolytics?
Good evening to one and all present here. At the outset, I'd like to thank Uttar Pradesh Society, Oxy, Jairani ma'am, and Sampath Kumari ma'am for giving me this opportunity. Good evening, moderators. Ma'am, with no cervical changes, only with preterm contractions, there is no need to treat the patient. There is no need to give tocolytic for those women. We need to monitor them, but there is no need of tocolytis.
Yeah. So thank you. So what you rightly said, that tocolytic use is not recommended if the woman is not in preterm labor. My next question is to Dr. Parul. Is there any role of non-pharmacological management of women with preterm labor, or does activity restriction reduces the risk of preterm birth?
A very good evening, ma'am, and thank you for this opportunity. Actually, now initially when we were PGs, we used to give a lot of this non-pharmacological management like maternal bed rest and reduced maternal activity and hydration, sedative use, all those things. But now it has been seen that these measures, they have not been found to be effective for preventing. And actually, activity restriction should not be recommended to reduce this risk, because it may lead to venous thromboembolism, because as we see the scoring of venous thromboembolism, so all these, when we see the scoring according to any of the guidelines, so it is one of the high risk. So we should not predispose the female to this bed rest.
Yeah. So activity restriction is not recommended to reduce the risk of a preterm birth. Yeah.
The pelvic rest is mistaken as bed rest.
Yeah. It should not be like that. Yeah. So my next question is to Dr. Gomati. A repeat examination few hours later finds that there is no further increase in the frequency of uterine contractions. So in addition to tocolytic that you gave, what other interventions will you do in this patient?
Yes, actually, giving a corticosteroids to accelerate the lung maturation, because the steroids is going to help to give a good neonatal outcome of this patient. That is, it is going to lower the incidence of RDS and the intraventricular hemorrhage, as well as the necrotizing enterocolitis and the need for mechanical ventilation. So how far it is better, and we see it, if it is getting delayed, we are very blissful. So if the birth is delayed for more than 48 hours with the early initiation of steroid, we can go for dexamethasone or betamethasone, whichever is available. If it is going to be a dexamethasone, it should be given as 6 milligram IM every 12th hourly, 4 doses. And if it is going to be betamethasone, it should be given as 12 milligram 24 hours for 2 doses. So the role of single dose steroid is still debatable, and it is there is both the neonatologist says that there is no need of steroids at all because if the baby has crossed more than 32 weeks because of the postnatal development issues. But still, as an obstetrician, we believe that the role of antenatal corticosteroid is beneficial for the baby.
34 weeks or 32 weeks, Dr. Reshma? You said 32 weeks.
34 weeks.
34.
So what the guidelines say that if there is early preterm, like if the gestational age is less than 34 weeks, a single course of corticosteroid is recommended who are at risk of delivery within 7 days. And further, if a single rescue course of antenatal corticosteroid should be considered in women with fetuses less than 34 weeks whose prior course was administered at least 7 days previously. So what I mean that those patients, like for example, who have come at 30 weeks, the corticosteroid was given, now her labor was arrested, and then she went into labor after 3 weeks. At that particular time, she has to be given a single rescue course of antenatal corticosteroid. That is what the international bodies recommend. But only these 2 courses will be required. Repeated courses of steroids are not recommended because studies have shown that there is a non-significant rise in the cerebral palsy rates with the repeated courses. So before 34 weeks, definitely we have to give a single course of corticosteroids, and in need, the patient may be a candidate for rescue course also. Hope I am clear.
Yes.
Yes.
Yes, ma'am.
Yeah, and my next question is to Dr. Kritika, that is there any role of repeated doses of antenatal corticosteroids in women with suspected late preterm labor? Like if she has come more than 34 weeks, then what shall be the like your point, your take in giving her corticosteroid?
Ma'am, there will be no need to give repeated corticosteroids in late preterm labor. Single course of steroid is enough for late preterm labor between 34 to 36 plus weeks.
Yes,
As
madam.
you said, it will do more harm than the benefit. So single dose is enough. There is no additional benefit from repeated dose.
Yeah. Yes, ma'am. You rightly said that the different international bodies, they say that we should consider administering a single course of corticosteroid who has come between 34 to 36 weeks, say 6 days. So now the couple is very much worried about the imminent preterm birth, and they have heard and read online about some medication which has which may reduce neonatal death and prevent cerebral palsy. So my next question is to Dr. Archana. How will you counsel about the medication, if any?
Ma'am, ideally, when a patient comes to us for preterm labor, steroid injections and magnesium sulfate has been helping us in both neuroprotection and lung protection. So if I am planning for an imminent delivery in the next 7 days, I would be counseling them to go forward with magnesium sulfate as neuroprotection because they say that it also reduces the risk of cerebral palsy in surviving infants. And ideally, any patient less than 32 weeks should go for magnesium sulfate. 32 to 34, it also depends and should be considered based on the weight expected, and should not be disregarded if the patient asks for it.
Yes, madam. So the couple has to be counseled that definitely there is a drug and they should be offered this magnesium sulfate if the delivery is imminent before 32 weeks of gestation. So also FIGO has given good practice recommendation on magnesium sulfate administration for preterm fetal neuroprotection. So madam, say what shall be the, say when it should be commenced and for how long it should be given?
Ma'am, it goes as per the routine recommendation. So ideally here we go for it with an intravenous route of dose. The recommendations, as explained before, would be any women at risk of early preterm birth, that is from a viable period from 26 to 32 weeks, we can go forward. And as I mentioned before, again 32 to 34 weeks, it can be considered. And ideally should be given at least before 4 hours of birth. We go forward with a loading dose of around 4 grams, and then we go forward with a dose for almost 1 gram per hour for another 24 hours. This is the recommended dose as per the guidelines.
Yeah. Thank you, madam. So magnesium sulfate has to be given for fetal neuroprotection, and the dose is the same as we use in pre-chart regimen, that a loading dose of 4 gram has to be given, followed by 5 gram into each buttock. So that makes 14 grams. And thereafter 5 grams intramuscularly into alternate buttocks every 4 hours for 24 hours. And this dose particular, it can be given as a 14, a loading dose of 4 gram, followed by a maintenance dose of 1 gram per hour if we have an infusion set. And it has to be continued until birth and stop after 24 hours if the patient remains undelivered. And there is no need of repeat magnesium sulfate for fetal neuroprotection if an initial course has been given. So the couple has to be counseled if the delivery is imminent, and the full dose has to be given. Once the dose is given, there is no need to repeat the dose. So thank you, madam. So my next question is to Dr. Indulata, that what are the adverse effects of magnesium sulfate?
Good evening, everyone. So, in adverse effect of magnesium sulfate, there might be chances of flushing, sweating, sensation of warmth, nausea, vomiting, headache, palpitation, and sometimes rarely there are chances of pulmonary edema. So these are adverse effect of magnesium sulfate in these patients.
So, and how will you say, is there any toxicity related to the use of magnesium sulfate for fetal neuroprotection?
At this dose, first of all, there is no need to monitor with the serum magnesium levels in these patients, and toxicity is very unlikely at this dose of magnesium sulfate. So we have to just monitor respiratory rate, deep tendon reflex, and urine output of the pregnant patients. And whenever there are changes in these parameters, like if there is absent patellar reflex, that is deep tendon reflex, or the respiratory rate decreases below 12 per minute, or there is decrease in urine output that is less than 100 ml in 4 hours, then we have to stop this, and we have to give the antidote of magnesium sulfate, that is calcium gluconate, and we have to give 10 ml of calcium gluconate, 10% of strength, within 10 minutes of infusion.
Yeah. So you rightly said that it is a safer, say, drug, but definitely we have to monitor all these parameters. And if we feel that there is a suspected toxicity, we should also know the dosage of the antidote, which is calcium gluconate. Sure. My next question is to Dr. Reshma. Is there any role of antibiotics in this 30-week pregnant lady in preterm labor?
Although intrauterine bacterial infection is a very important cause of preterm labor, but prophylactic use of antibiotics is not recommended unless until the patient is presenting with the sign and symptoms of bacterial infection or presenting with the ruptured membranes. Only then we have to give antibiotics, otherwise no rule.
Yes, madam. So antibiotics routinely should not be used in these patients.
Dr. Sonia, can I interrupt?
Yeah, ma'am.
We have
Yes,
to
madam.
do this urine for culture sensitivity is very important. We have to do complete urine examination also, which is very common during pregnancy. If there is urinary tract infection or asymptomatic bacteriuria, definitely we have to treat with antibiotics, or else antibiotics will not be used.
Yeah.
CBC, complete blood count, and CRP will be helpful to decide about the role of antibiotics.
But unless madam patient is having any complaint, like if she's complaining of like any UTI like symptom, but again asymptomatic bacteriuria in pregnancy needs to be treated. That is what madam is trying to say.
And Sonia, we have to talk about bacterial vaginosis also.
Yeah. Thank you, ma'am. Now my next question is to Dr. Kritika. The above patient has gone into active labor. Now, how should we do fetal monitoring in labor in this patient of preterm labor?
Yes, ma'am. Once the patient is in active labor, she's a high-risk candidate. Fetal monitoring is very essential. We need to have an informed decision-making, shared decision-making along with the patient and the partner. We need to discuss about the importance of fetal monitoring and the benefits out of the fetal monitoring with the patient, also with the family members, without any comorbidities like GDM or any other gestational hypertension or any other risk factors. Either intermittent auscultation or CTG are equally effective in monitoring the fetus. In case of any other risk factors, CTG will be more helpful. CTG monitoring will be needed for monitoring the baby. In case the CTG is reassuring, it is very good. But in case abnormal trace does not necessarily mean that there is any fetal compromise, we need to clinically monitor the patient along with the CTG for safe delivery.
Yes, madam. So in this particular patient, it is very tricky because these are the preterm babies, and we have to take care while we read the CTG say readings, because this has to be taken in context with the preterm babies. So here CTG or intermittent auscultation, it can be offered to the patient, and it has not been shown that CTG is superior to intermittent auscultation. So my next question is to Dr. Sangeeta, that the above patient is in active labor. What shall be the mode of delivery? And when will you do cord clamping at delivery in this preterm labor patient?
Yeah, if there are no other contraindications, then the vaginal delivery would be preferred over cesarean sections. If there is any malpresentation or she's having placenta previa, then obviously we'll resort to cesarean sections. Otherwise, the vaginal delivery would be preferred. We will never use ventouse in cases of preterm babies. And even the forceps nowadays, nobody is really using. Initially, we used to use outlet forceps, but now even that is not being used. And the cord clamping should be delayed by 60 seconds or till the pulsations are they disappear. And obviously, we have to keep the baby below the level of the placenta before we do the cord clamping. And in case the cesarean sections are very difficult in such babies, in such cases, because the lower segment is not well formed. So we have there could be extensions, there could be excessive bleeding in such cases. So as far as possible, if there is no other contraindications, then vaginal delivery would be preferred.
Yeah, so definitely, ma'am, what you said that is right, that vaginal delivery is preferred in these women, and cesarean section is done for obstetric indications, like if there is a malpresentation with prematurity. So that is other issue, and we should do a delayed cord clamping in these particular babies. So thank you. Also, now I will invite my colleague, Dr. Sonia, for the next panel of questions. Dr. Sonia?
Thank you so much, Dr. Renu. I'll start my presentation. Actually, it is in continuation with what we have just now discussed with Dr. Renu and all the learned panelists. And I would just add on few things. Let me share first the is it visible? My screen is visible?
Yes, you are visible and audible too.
So thank you so much for giving me this opportunity. This is an important topic, and Dr. Renu has almost covered all the topics. What we are left with is the prediction and prevention of the preterm births. I invite all the panelists to give their inputs, and I will also request our experts, Dr. Aruna and Dr. Seema, to give their valuable comments wherever they feel like. So we all know that the burden of preterm birth is so much in India that around 25% of overall preterm related deaths are in India, and that is also true that in spite of all the efforts, mortality and morbidity due to preterm births would have not been brought down to very low levels. So what we are supposed to do is we need to focus on how to predict and prevent the preterm labor. So by knowing all the high risk factors and understanding the etiology, what has come out to be the strongest risk factor is previous preterm delivery. Because after one preterm birth, the risk is 20% in the next pregnancy, and after 2, it is 35 to 40%, and after 3, more than 3, it becomes even higher, more than 50 to 60%. So this has come out to be the most important risk factors to be considered in all the patients. The second thing, which is in our hands as per obstetricians to understand the one more important predictor, which is the cervical length, and we can see it very well through transvaginal sonography. And again, this again has in various studies have found to be a very important risk factor. So based on few cases, we'll try to understand how to proceed in such cases. So a woman who is of 24 years, she is P0+1 and with previous preterm labor at 22 weeks. So she has come to the OPD. What should be our move regarding how to monitor her for cervical length or any other factor what we want, so that we can predict whether she's at high risk again or not. So I will like Dr. Parul to please take up this question, what she would like to monitor this patient, when she will like to monitor this patient.
Dr. Sonia, as you have already told that in this, since she also has previous preterm delivery, and so she's very high risk that she may have preterm delivery in this case also. And so we have to do serial sonographic assessment of the cervix, and which is usually performed between 16 to 24 weeks of gestation.
Yeah, that's the most important time when we should be calling the patient, and probably anatomy scan, the TIFA can also be done at the same time, and along with TIFA we can do this cervical length measurement also. What do you think, Dr. Parul?
Yes, it can be done because sometimes the patient may not come to us so often, and we can repeat it. We can do this cervical length assessment along with our TIFA scan, which is usually done between 20 to 22 weeks. So that would be okay. And but if the patient is very, sometimes the patient may have that they are very apprehensive, so they may come earlier also. They may be ready to come early, so we can get it done at that time.
Yeah, so that's a crucial time. We should definitely be doing cervical length in such patients. So as Dr. Parul suggested, that patient
Sonia, I would like to add one thing here.
Yeah.
That the cervical length should always be done through the transvaginal route.
Yeah.
Because the transabdominal, because when we measure the cervical length, we always have the patient has full bladder that falsely elongates the cervical length, and it also suppresses the funneling. So it should always be done through the transvaginal route.
Yes, very well taken. So that patient came at 18 weeks and her cervical length was found to be 22 mm. So what can be the management in such case? I would like Dr. Uma is there, or anybody else. If Dr. Uma is not there, anybody would like to take up this question. So what can be the protocol in such patients when we find that her cervical length is short?
I can take up this question because
okay. Yeah. Sorry, go ahead.
Because she has a short cervix, we know, and she previously preterm labor, as we have already discussed. And in other cases also with a short cervix and previous less than 2 spontaneous preterm or mid-trimester losses, that means 16 to 34 weeks. So ultrasound indicated cerclage can be offered, or she can be given prophylactic vaginal progesterone. So both the options can be discussed with the patient, telling her about the pros and cons. But we know that since that is a surgical procedure that involves surgery, cerclage, and this vaginal progesterone that can be given even that is very convenient for the patient to take. So the patient maybe will definitely opt for this vaginal progesterone.
Yeah. So very rightly said. I have been mentioning all the guidelines also, although I have mentioned the older one, a little older one, because what we have been doing in last decades are as per these guidelines. So RCOG recommended ultrasound indicated cerclage, whereas NICE also suggested to offer both the options and discussing all the choices, all the risks associated with both the options. So FIGO has also published in last 2-3 years back good GCR practices, in which they have also suggested that an ultrasound indicated cerclage can be offered in such women who have less than 2 preterm births losses, and this time they have again the short cervix. So coming to the other one, like progesterone. So as per NICE, they also suggest, as Dr. I think Parul has answered. So Dr. Parul, just the choice of both the things can be given, and definitely if non-surgical method is equally good, so that should be the preferred one. So in various studies, it has come, it has been brought to the knowledge that vaginal progesterone is equally good as of cerclage, and being a non-surgical method, it can be as effective and better tolerated by the patients. So now it's time, most of the time we offer both of them. And
excuse me, Sonia, one point I would like to add as far as the progesterone is concerned. It not only stops the thing, it will maintain the continuation of the tocolysis also by using the progesterone. So that is an advantage of that.
Yes, thank you so much for the nice input, ma'am. Progesterone has many benefits, but again, if the patient has opted for the progesterone, what should be the preferred route for progesterone? Because traditionally we have been using intramuscular progesterones. Now we are there with vaginal as well as the oral preparations. So any comment on this, Dr. Reshma? What is the preferred route for progesterone, and why you prefer that?
As we all know, there are 3 routes of administration, that is oral, vaginal, and intramuscular. And each one of these 3 having its advantages as well as disadvantages. Coming to one by one, oral route is the easiest one. It is better, patient compliance is better, better acceptability, better tolerability, but there are few side effects like dizziness. And the concentration of progesterone in the blood by oral route is not so much high. Next is vaginal. It has got the advantage of first uterine first pass, and the uterine concentration is the highest in the vaginal route. If we compare the vaginal with the intramuscular route, the ratio of uterine and peripheral concentration is 14:1 in vaginal route, whereas it is 1:1 in intramuscular route.
Yes.
So the vaginal route is the best route, but it has the disadvantage as it needs privacy for administration, and in some patients there may be vaginal irritability and dryness. And third route is intramuscular route, which maintains the blood level concentration, almost maintains the blood level concentration, but the uterine concentration of progesterone is not so much as in vaginal route. And in preterm labor, after repeated injection of progesterone, the patient may have abscess formation, and the injections are very, very painful also, and there is abscess formation. So by comparing, if we compare all these 3 routes, the vaginal route is the best one as far as the prevention of preterm labor is concerned.
Yes, so very well explained, Dr. Reshma. As we see in this picture also, that the concentration is so much high in the uterus with the vaginal route that it has to be more effective. And the studies have also shown the similar response that first of all, AJOG has also published a study in which they showed that the vaginal progesterone is non-inferior to injectable one for prevention of PTB. And later on, it has been found that it has been very effective in reducing the reducing the preterm births as well as the respiratory distress, RDS, neonatal morbidity and mortality. BJOG published an article which actually it was a meta-analysis which included comparison of all the routes of progesterone, that is vaginal, oral and injectable, as well as they compared the cerclage and pessary also for preventing the preterm births. And the revolutionary thing they come out with that the only vaginal progesterone was found to be the intervention which has consistent effect for preventing preterm births in singleton pregnancies, at high-risk pregnancies. So it was a huge meta-analysis which included more than 11,000 women. So it has a great impact on our practices also, and I think everyone is using now the vaginal progesterone. And it is now a standard of care. I hope everyone will agree to me. So,
Sonia, one comment.
Yeah.
Can I give one comment, Sonia?
Yeah, definitely. Welcome.
So, just to say, I mean, what we have seen in our practice is that like the progesterone for the preterm labor. So,
Yes.
whichever progesterone you use or whichever route you choose, you should use only one type of progesterone only. Either you are using.
Hello. Hello. Hello.
I think some
Hello.
Connection is, I think it is.
Okay, I think I thought
to hear Dr. Seema.
Yeah, Dr. Seema. Dr. Seema, we cannot hear you.
She lost connection, I think. She's not there.
Okay. So,
Actually, Dr. Sonia, I just wanted to add one point that we all know that vaginal progesterone should be used and we prescribe it at first. But most of the time, the patient, they want to take orally. They do not want to take it vaginally. They come to us and they say that I've started having irritation and those things. So we have to shift many cases. We have to shift them to oral. So many times, I don't know what are the experiences of others, but most of the time, many times the patient, they want it orally.
Yeah. If you want to switch over to oral, you could prefer a sustained release.
Yes.
Yeah, but with the oral preparations, there is a first liver pass effect, less effective, whereas the similarly uterus first pass effect with the vaginal, it makes it actually. So that is the two major things we should be remembering, and thoda sa counseling and everything can add on to the patient's acceptance. Definitely putting vaginally a tablet twice a day for a long time makes a little uncomfortable. But I think people who are doing IVF, they are very much used to it. They are using day in, day out patients, so they are writing vaginal. But yes, many of us probably are still writing injectable and oral. So what Dr. Seema was suggesting, I think, was she was trying to say that you should be using a single, whatever you are using. If you are using vaginal or injectable or oral, you should be using only.
Yeah, I'm back, Sonia. Sorry, I got
Yes,
disconnected.
Dr. Sonia.
Dr. Seema, are you there?
Yeah. That is what I was to say. I got disconnected. So, whichever route, whichever progesterone you decide to choose, that is fine. But use only one progesterone, because there's tendency to use multiple types of progesterone with multiple routes, so which is not the right practice.
Yeah, we have seen people being flooded with all kinds of progesterone, anything which is available in the market. So that's true. That should not be a practice. One route is good enough. So proceeding to the next case, a woman who is 31 years old, P0 plus 0, but on a routine anomaly scan, her cervical length was found to be 20 mm, which is a short cervix. So what should be the next step? Dr. Gomati, would you like to comment on this?
Yes, ma'am. She is an asymptomatic woman with short cervix. The short cervical length could be a normal phenomenon, okay, not necessarily a definitive marker of preterm labor, ma'am. So ultrasound indicated without asymptomatic patient means there is no need for cervical encerclage, but we can consider prophylactic vaginal progesterone because the cervical length is 20 mm.
Yeah. So NICE have suggested to use prophylactic vaginal progesterone in such cases of short cervix, even though there is no history of preterm losses. But again, RCOG has advised not to intervene in such cases. That was the older recommendations, but even if we see the latest one, in which also the NICE also have suggested to consider prophylactic vaginal progesterone for women who have either of the 2 points, that is history of preterm or short cervix. Either of them will make her a candidate for vaginal progesterone supplementation, and that is the guideline from NICE, and they have also suggested to start between 16 to 24 weeks whenever you have diagnosed that condition and continue until at least 34 weeks. So there are different school of thoughts. So, but still, I think it depends on your clinical acumen and your practice that you can offer the vaginal progesterone, and if the patient is comfortable, or you can continue with progesterone. So that one thing, and then coming to another case, which is a little different from the previous one, 35 years old female with history of 3 recurrent losses, 18 weeks, 22 weeks, and 23 weeks. Now, what should be the protocol in such cases? Dr. Archana? Dr. Archana? Are you there, Dr. Archana, or anybody else want to take this question?
Dr. Bharani is being seen here.
Yeah, ma'am. I'll take it, ma'am. So basically, this is she's got previous 3 preterm deliveries, and she's a 35-year-old. So this itself, she needs a history indicated cervical cerclage. So ideally, around the 12 weeks after we've done an NT scan and we've made sure that NT is normal, we can go ahead with a history indicated cervical cerclage because she's had 3 previous miscarriages in the past, ma'am.
Very rightly said. Even if there is no need to do ultrasound, you can go ahead with history indicated cerclage at 12 to 14 weeks, done it a little earlier than the ultrasound indicated cerclage. So this is the recommendation by FICO also, that if there is a history of 3 or more preterm deliveries or mid-trimester losses, we can go ahead with the history indicated cerclage. And this is the most specified indication for cerclage. Even the studies have also indicated that the maximum benefit getting out of this cerclage are the people who have more than 3 or more than 3 pregnancy losses. Whereas in the lesser losses, the benefit is not that much, although they will also get benefited, but benefit is not that much. Maybe less than 3, the cerclage and progesterone stand equally, whereas in 3 or more than 3, cerclage has a upper hand. So that is the recommendation, and the studies which have shown. NICE have suggested that if there is a history of PPROM in the previous pregnancy or history of cervical trauma, that should also be, that case also should be considered for a prophylactic cervical cerclage, that is history indicated at 12 to 14 weeks. So this is the NICE, and this is just a picture to show where the various cerclages in the put. There's also a recommendation by FIGO that if we fail with the vaginal cerclage and that patient is history indicated cerclage, and if you feel that cerclage will definitely going to help, then we can go ahead with the transabdominal cerclage. So the next case is, I think Dr. Kritika, if you would like to take this case, there's a lady,
Yes, ma'am.
the same lady who has underwent cerclage at 14 weeks. And when she turned up again for anomaly scan, you revealed that the cervical length is still 8. So is there anything which you can still do for this woman?
At this time, we have two options, ma'am. One will be expectant management to observe. Second will be to do a recirclage. But the repeat cerclage is not recommended because the harm and risk out of repeat cerclage is more when compared to the benefit. Infection and other things are more with recirclage. So international bodies do not recommend repeat cerclage. Expected management should be considered in these conditions.
Yes, yes, very, very rightly said. Repeat cerclage is not indicated because harms can be more than the benefits. In fact, expectant management with addition of progesterone can be given. So, adjunct vaginal progesterone treatment resulted in older gestational age at birth and higher birth weight. This is the study which has been showing this result. So the next case is of a 28 years old female who is P0 plus 0 DCBA twins, and it is a spontaneous conception. So what do you think in such patients, if you find on a routine anomaly scan, if you find you should be seeing cervical length, and what should be your take on the cervical length in such patients who are not at no history of midterm losses, but they are having multiple pregnancies? So maybe Dr. Bharani or Dr. anybody else?
Unmute, Bharani.
Yeah, Dr. Bharani.
Yes, ma'am. Sorry. I didn't realize I was muted. There is, since this is a spontaneous conception and she's a preemie, she's not had any history, there is no need to give a prophylactic cerclage just because it is a multiple pregnancy. Because yes, we are going to expect some amount of cervical shortening. And the NICE guidelines recently, the one that came last year, is saying that you can do a ultrasound between 16 and 24 weeks and measure the cervical length. And in case the cervical length is less than 2.5, you can consider giving vaginal progesterone. But they've also very clearly said that there is no rule for doing a cerclage for a spontaneous conception just because she's twin. That is one thing, ma'am. But of course, in common practice, we see most commonly twins, if they have conceived after an ART or after previous miscarriages, some special treatment after ART, they have conceived. We do see as a common practice that there is an elective cerclage in early weeks. But the guidelines very clearly say that there is absolutely no benefit in putting a cervical cerclage just with the intention of preventing preterm labor.
Yes, rightly said. Although there are guidelines, you need not be putting a cerclage in multiple pregnancies, but many a times people put it. And in fact, FIGO good practice recommendation have also pointed out that even though 25 mm length in multiple pregnancy is not an indication for cerclage, maybe less than 15 mm can be considered. They have written a line like that. So maybe in coming years, we may find other guidelines regarding this. So as such, for at present, the progesterone is the drug of choice for such women. Although it is not found any significant difference in a patient who has only twin pregnancy or twin with short cervix. So there's a little gray zone, and maybe the clinical acumen places are placed at a higher state. So
Can I add one more thing? I, being a IVF specialist, IART pregnancy, seeing more than 30 years, having a lot of twins in my in my practice, I strongly suggest, because there are some guidelines, even in the NICE guidelines, what they say is a cerclage can prevent a preterm PROM, because sometimes in a twin pregnancy, there is always the external las and the internal las may be slightly open because there will be a bulging of membranes always with a shortening. So that exposes the membranes to the exterior and that induces infection and PROM. So definitely there is a role of cerclage which can prevent a pre-ROM in this type of a women, because especially that side of infections can be prevented by putting a cerclage, which can help to prevent the exposure of this bulging membranes, because as the pregnancy grows, this has been one word that is included in the guidelines, if I'm right, because I didn't go through it because it is it is one thing which can prevent in cerclage in twin pregnancy.
Yeah,
Ma'am, can I also?
Thank you, ma'am, for the valuable input. Actually, what we are discussing here is the guideline, but what you have suggested is the actual practical thing what we are being done.
Ma'am, can I also add a point? Sometimes it's also patient indicated, because sometimes they just hear, say, or they read, some other patient tells them,
That
and then
always-
they themselves come and ask, why have you not put a cerclage for me? My friend had it, or something like that. They come and ask. So
And
that
if you
is
lose the
force-
pregnancy, that is the end of you.
Yeah. So sometimes you're just forced to do it because the patient is insisting.
Right, rightly said, ma'am. So now as we were discussing the cases of IVF, we'll again discuss another case, which is a singleton. Sorry for the spelling mistake. Singleton pregnancy conceived after IVF with no previous losses. So in such cases, what should be the take? Dr. Indulata, if you want to throw some light on this.
Yes, yes. If there is singleton pregnancy, IVF conceived, and on ultrasound, if on ultrasound during 16 to 24 weeks, we find that cervical length is less than 2.5 centimeter or 25 millimeter, then we can recommend vaginal progesterone 400 microgram per vaginally, 400 milligram per vaginally. And if there is no history of prior preterm birth, then we can recommend the vaginal progesterone, and we have to do the cervical cerclage only when there is cervical length is less than 1 centimeter. So this is, but if singleton pregnancy with prior preterm birth, then we can consider for this progesterone, micronized progesterone, if the cervical length is less than 2.5 centimeter ultrasound, and even we can consider for cervical cerclage if there is the cervical length is less than 2.5 centimeter on ultrasound. So we can consider both the vaginal progesterone and as well as the cerclage, cervical cerclage.
Yes, as ma'am has said, that it will prevent or reduce the incidence of PPROM. So that way we can use it. And but what the studies have told that the progesterone may be it can significantly lower the preterm birth rate in singleton pregnancies, but there was no significant difference was found in twin pregnancies.
Yeah,
with IVF, yes. So this is the guidelines, and this is the latest one, which is by the American College of Obstetrician and Gynecology. I'm sorry for the small font in this. You can just take a pic and then zoom and see. So in which they have just recommended that singleton pregnancy with no prior preterm birth, only the cervical length is less than 25 mm, then you can go for vaginal progesterone, no cerclage, nothing is indicated. Singleton pregnancy with spontaneous preterm birth losses in the history, you can consider either progesterone or the cerclage, offer the patient whatever she wants in multiple gestation. Nothing is required as such for the non-high risk cases. So this is the guidelines by ACOG also. There's a of late we have also been using cerclage along with progesterone, and also the studies have come for the combined treatment. So combined treatment is always, I think we have always seen in practice that cerclage along with vaginal progesterone achieves a greater reduction in preterm birth compared to a single therapy. So that can be used as depending upon the cases and depending upon the practice. So this is also an article from AJOG which has recommended the combined therapy. So for using progesterone for such a long time in pregnancy, is progesterone safe, Dr. Sangeeta?
Yeah, we are using progesterone for more than 10 to 12 weeks. If we consider between 24 to 34 weeks, we are almost using more than 10 weeks. So it might have some detrimental effect. This is all theoretical, that it might have some detrimental effect on the mother as well as the fetus. And the optimum trial, which is the largest trial which was done, which studies the vaginal progesterone prophylaxis on preterm birth. And it showed that we have been discussing progesterone since long, almost half an hour, but it says that it doesn't make any difference on the occurrence of the preterm. It doesn't prevent preterm, and it doesn't prevent any neonatal outcomes. It doesn't prevent any childhood outcomes. So, so still there is an unmet need to find out what subgroup or subset of patients are there, what phenotype, what genotype is there, where this is really effective, and it does prevent some neonatal like it prevents the neurodevelopmental outcomes in the neonate, or maybe the cognitive impairments in the childhood at age of 2. So all this, it still needs more studies. So therefore, the optimum trial, which is the largest trial, it says that the primary outcomes are not very encouraging, and progesterone just doesn't it doesn't prevent the preterm births, and it doesn't changes the neonatal and the childhood outcomes. So maybe there is subset of women where it does affect. So although there are no much of side effects, because we've been given progesterone since long, we haven't seen any side effects for the mother as well as the baby. So
so that means we can use it safely because it has no as such effect.
As of now, we can, but still more studies are required.
Dr. Sonia, there are few studies that indicate the skeletal system is disturbed. The development is not good in the fetus that is exposed to prolonged progesterone. And the sexual organs are also not that well developed. If we give prolonged progesterone, that also we have to consider, but we need more studies. Yes.
Okay. Ma'am, any comment on the condition of IHCP? With the use of progesterone, we get more cases of IHCP. So is there any comment for that?
It does. It does.
Yeah,
it does.
It does, yes.
So any comment from all the wonderful panelists and our experts are welcome. So this is it from me today. Thank you so much for participating so actively and making it so informative. Even for me, after studying so many things, I still gained so much from the expert opinions of the panelists and experts. Thank you so much. Any input is highly welcome.
Though we say either or, but still many practitioners continue both cerclage as well as progesterone.
Yes, ma'am. That is
a word about 17
Even we do it, ma'am.
Clinically, the word about the injection.
I think that is the common practice, ma'am. Ma'am, that is the common practice. We use both. Whenever we are giving cerclage, we do give progesterone.
That's what I say. And as somebody was talking about 17
progesterone, ma'am. Yeah, that also is nowadays.
That has come back again.
Again, yeah. That's what. That also prevents whatever usual Proluton has come again for the prevention of preterm. That is also one thing that we can have as a common routine, because sometimes the vaginal progesterone, the patients, their compliance will be very much bad. They cannot accept a vaginal tablet when you put a cerclage, especially in our setup and all. We need a lot of coaxing, we need a lot of confirmation, we need a lot of emphasis, but that is very difficult. So in such case that we find the 17-hydroxyprogesterone has an equal better outcome. We don't have a proper data and studies, but definitely in our clinical practice, we have equally safety when we use 17-hydroxyprogesterone.
And now we also, like, after circulage, like, we at our place we give Isoc Supreme drip also for 48 hours.
To
We
try to
give
block
the common
on all
practice, yes,
sides.
ma'am. And then we follow it with intramuscular Isosupreme for another 48 hours, and then we taper it. So
Yes, you're right. We're also doing.
I think Dr. Jairani is so right. There is a lot of psychological phenomena also behind it. Injection gives so much psychological relief to the patient that everything is going to be right now. Whereas for vaginal tablet insertion, there's a mental hindrance in
block,
and they discontinue it.
And there's another
after
problem
few
with
days.
with vaginal progesterone. We also fear that there's chance of introducing infection also, because we are not sure whether patient is putting it hygienically or not. So that is why we are not very comfortable with vaginal progesterone. So
For encerclage, I want to add that you should do a high vaginal swab before you give the encerclage, and at the removal also you should do a high vaginal swab. And you should use monofilament threads because it doesn't attract infections. So you should be very careful. And when you apply the cerclage, you should have a plan for removal also when you will remove. A plan should be beforehand for removal.
I just want to add up. We this time in the South VP conference in Kanyakumari, we had Dr. Rajan. He was talking on this preterm birth prevention from UK. He has done a lot of studies. He has given the latest data stating that almost a cerclage, even for shortening, he's indicating that the cerclage is the one for prevention, because previously in all our RCOG guidelines and all, they differ. But he has given exactly what our Indian practicing scenario is, the upcoming trend in UK. That's what he was talking, because when I heard him, it is just like an Indian talk he was talking, because everything, whatever they put into this guidelines from UK present risk data is almost like our own practice. And one more thing I just want to tell, that prevention, almost all pregnancies needs a high vaginal swab at 14th week, 14th or 15th week. Always that can be done, because in our country, we have to do, because that can prevent a lot of PROMs and preterm birth.
And urinary tract, urine analysis also.
Urine culture. One vaginal swab and culture
Must.
together.
Must.
Right. Well taken.
Okay, thank you. Bye.
Okay,
Very good.
so nice.
Nice
Madam
job.
Revati, madam, very special thanks for your
Thank you,
senior
thank
expert opinion, which is really a very important one, which we all look forward. Thank you, ma'am. Thank you so much for
Thank
joining
you.
us.
Thank you. All the best to both of you. Thank you.
Thank
Bye.
you, thank you, ma'am. Thank you. A very
all the
special
best,
thanks
all the
to
best,
the.
Rani ma'am and Dr.
Thank you,
Arun,
thank you,
for
thank
the
you.
upcoming
So
election.
as a
Thank you,
formal,
Dr.
as a
Seema. It
form,
made all the
as a formal
difference.
thanks, I thank all the UP, the chief guest, Dr. Chandravati madam, the guest of honors, Dr. Preeti Kumar, Dr. Manjula Shukla madam, and also Meera Agnihotri madam for gracing their presence, and a very special thanks to Sampath and all the UP societies, especially Lucknow Obgyn Society, for your dynamic participation, and from Faizabad, Gorakhpur, Kanpur, Hapur, and Faizabad for joining us in this webinar. A very special thanks from our Oxy Society, Obstetric Gynec Society of Southern India. We thank you one and all, and we look forward, all the president and secretaries, to cast your vote for the No to Violence Against Women Committee Chairperson election for me and for Dr. Aruna.
Thank you.
She's contesting for the International Academic Research Committee. We need your blessings to work more for Foxy with a lot of enthusiasm. Thank you
ma'am,
so
and
much.
thank you,
And a
madam.
very
Thank
special
you.
thanks
All the
to
best,
Seema.
Thank you, ma'am.
Very special thanks to Seema Mehrotra for all your blessings. And again, we are meeting again on 8th, again with other societies, with her guidance and with their support. And a very special thanks to Preeti for all her passionate, very much passionate involvement in this academics, which is really a wonderful thing that we all should inspire. Thank you.
And thank you so much, ma'am, for involving logs and giving us this opportunity to interact with you all. And a special thanks, I would like to thank my moderators, Dr. Renu and Dr. Sonia, for
amazing.
my
very nice.
Dr.
Very
Renu
nice,
and Dr.
very nice.
Sonia, your
Renu and
excellent
Sonia,
panel.
so nice, so fantastic.
Many
all my panelists,
Every
Parul,
depth of the preterm practicality you have put into the panel,
So
and
a very
really I
nice
appreciate.
panel.
I'm very thankful to my Oxians here, Dr. Barney, Dr. Kirtika, who had joined very lately, but still with a lot of energy. Thank you so much, dear, for joining here.
And ma'am, thanks to all the
Thank you, ma'am,
panelists for accepting the invitation at such short notice. Ma'am
Thank
Parul,
you,
Dr.
ma'am.
Sangeeta, Dr. Indu.
Everybody, right? That's so
And
kind.
thank you,
That's
Dr. Seema.
Gomati, Dr. Gomati, everybody, they joined with passion. Thank you so much.
Thank you, Jairani.
Thank
you, ma'am.
Thank you, Aruna. Thank you.
and all the
Bye.
best.
Bye.
Jairani
Bye.
ma'am,
Good
Sampath
night.
ma'am.
Thank you.
Very nice.
Meena, very special thanks to my secretary,
Thank
our
you.
Oxy,
Thank you, madam.
for your dynamic talk. Thank you, Meena.
Thank you,
Thank you
madam.
so much.
Thank you.
Thank you.
Thank you,
Thank
madam.
you. Bye. Bye.
Good
Bye.
night, everyone.
Good night. Good night.